Hello, my name is JustinHowe, and I am a student in the OHSU PSU School of Public Health. Today I'm coming to you with a qualitative, community-based participatory research proposal, GLP-1 medications in the treatment of obesity and overweight. Now, obesity is not merely a lifestyle issue, but a complex disease state because obesity is a disease and cluster of many disease states, and it's also a public health crisis. There's new attention to GLP-1 medications for weight loss when these medications were originally for diabetes, type 2 diabetes. These medications include the well-known Ozempic, Wegovy, Mounjaro, and Zepbound. There's been a lot of discourse in the public and media, which has reduced the use of these medications to cosmetic uses. Basically, that there are no medical needs for these in populations who are trying to treat obesity and overweight. Interestingly enough, these medications were not controversial when they were only being used for diabetes. So here we have obesity is noted as a BMI of greater than or equal to 30, whereas the overweight category is a BMI of 25 to 29.9. And unfortunately, BMI is still a poor metric in this disease state, but it is what clinical trials and evidence-based research still uses. Obesity and overweight is strongly associated with comorbidities such as type 2 diabetes, cardiovascular disease, and hypertension. And as you will note here, there is a 7-fold increased mortality risk for type 2 diabetes in those with obesity. Diabetes will not be the focus of this presentation, even though these medications are also used for type 2 diabetes. The importance here is that these medications could have preventive effects against these comorbidities if people can gain access to them. So current research shows that over 40% of US adults are obese. Unfortunately, we also know that these rates are higher in Black and Hispanic communities due to a lot of disparities, social determinants of health. There's actually a lot of intersection of disparity when it comes to any treatment in these populations, but especially these medications that are out of reach due to cost, and generally insurance doesn't want to cover these, and they are prohibitively expensive out of pocket. Obesity and overweight is also shown to be linked to depression, anxiety, and disordered eating. So again, barriers to progress we have here, like I've said, there's a very high cost, there's limited insurance coverage, the stigma of these medications being used in this disease state as cosmetic or that people are cheating to lose weight. And also the media just simplifies this complex disease state and the health needs around it. Going back to stigma, you see a lot of things out there in the media that people living with obesity and overweight just need to work harder or get off the couch or stop being lazy. But these conditions are so much more complex than that. For some other stuff that was happening in the media when these medications were first starting to gain traction for this disease, there were a lot of celebrities that were using it or almost pseudo-endorsing the use of these on all kinds of social media for the use of, really just losing weight. They weren't highlighting the fact that these were supposed to be treatment of a disease for obesity and overweight. There was just a lot of media hype around how this was just a quick way to drop some pounds. So the GLP-1 medications, their chemical names are semaglutide, liraglutide, and tirzepatide. And again, these brand names are Ozempic, Wegovy, Mounjaro, Zepbound. That's what you'll see in the media or any, maybe some of the research, they'll probably have the chemical names listed. They're These are FDA approved for weight loss and type 2 diabetes. They were originally for glycemic control in diabetes. But there are new FDA approvals and a growing pipeline of other drugs coming out. Some of these medications right now, they're starting to get new FDA approved indications for cardiovascular issues and sleep apnea, which are both comorbidities with obesity and overweight. Why this is important is the more FDA indications these get, the more it will open up access for people to get insurance coverage and probably drive the cost down as well. So as you see here, uh, liraglutide has about approximately a 5% weight loss. Semaglutide has approximately 12% weight loss, and tirzepatide has up to 20% weight loss. Um, Unfortunately, efficacy is still measured in weight lost, which again is not the best metric, but it's what studies have so far. Future studies will need to consider reductions in comorbidities as well and prevention of other poor health outcomes. These numbers do look small on paper, but you have to consider that this still can equal substantial pounds that are lost, depending on your baseline weight. You know, 5 to 20%, that could be a phenomenal amount of pounds lost. These medications also have a lot of cardiovascular benefits, not only in type 2 diabetes patients, but they're also finding in the research that secondary prevention around those who have had myocardial infarctions, strokes, it will actually help prevent those from occurring again. So, as with all drugs, these come with some side effects. These side effects are well known and documented. The common ones are GI distress, mostly nausea and vomiting. These medications are usually prescribed in tandem with antiemetic medications such as Zofran or Phenergan for nausea and vomiting for the first month or so that you're on them. There are some rare but serious side effects, again, just like with any drug. And so that's where we come into the importance of monitoring. Um, Again, adverse effects are rare, but we do have to be mindful of them because they can cause damage to a person's overall and long-term health. Qualitative research is interestingly showing that people are willing to tolerate these side effects or risk of adverse effects for the potential benefits. So people are very interested in using these drugs for treating their disease states. You have to consider that these medications are second or third line treatments. Usually by the time people get to them, they've probably tried several other treatments such as other medications, bariatric surgery, lifestyle changes. So by the time they get to this, they've tried several other things usually. So some more qualitative data here is use of these medications alone, not just for the weight loss. There's improved mood, self-worth, social engagement. Of course, physical improvements usually enhance our mental well-being. If we're happy with our body, we're usually happy with our mind and vice versa. And there is research showing reductions in depression and anxiety with use of these medications as well. Interestingly enough, a lot of people describe a reduction in what they call food noise, which is the drive to eat when not necessarily hungry, or any other kind of disordered eating. So like emotional eating, things like that. People are describing that kind of goes away, and they're finding other things to do to fill their time with, where they would usually have disordered eating patterns. Um, so that is very interesting, and it's mostly qualitative data right now, of course, because it's a little bit vague, but it is still a very interesting concept of the effects that these are having on people. So while these medications have a lot of data in the use of diabetes type 2, data in overweight and obesity is still relatively new, but more is being published every day. And we know that there is stigma and access challenges now, but we also have to look forward to the future and what other kind of barriers we'll see going forward. So the unanswered research questions that I would like to address are, what are the lived experiences of people using GLP-1 medications for obesity and overweight? Also, how do they navigate the cost, the stigma, provider relationships, and mental health effects of using these medications or not being able to use these medications? So a CBPR framework will be key here because it is collaborative, reciprocal, and equitable. And it will allow the participants to act as co-researchers and not just subjects. Again, we're looking for respect, reciprocity, and responsibility for everybody involved in the study. And it's really about a community partnership model. We want to engage with patients that are trying to use these medications or are using these medications. Pharmacists, because they are the closest to really the evidence of the medications. They're probably going to know the most about how these work. Clinicians, providers who would actually prescribe the medications, and just patient advocates of all kinds. We're going to need people from diverse backgrounds, of course, and varied perspectives, because again, there's a lot of disparities in subgroups and subpopulations to people with obesity and overweight. And it's just going to be important for us to build trust through continuous dialogue. So the data collection plan is going to be semi-structured interviews, standardized questionnaires, which are some right there that you can see. There will be online and private interviews to reduce stigma depending on how comfortable people are in being in public or face-to-face. We have to be mindful of that. And I'm going to use purposeful sampling, so actually, get into these populations to the people that I actually want to work with, because those are where the marginalized voices are, right? Referral sampling, if necessary, just in case I cannot find enough participants, but I really don't think that's going to be an issue. So the data analysis plan will be reflective thematic analysis with template analysis to allow for a priority and emerging codes with room to develop other themes as the study goes on. And it's really important to focus on this again, to say this again, that the participants will be part of the process, and participants will help in involvement of codebook development for qualitative research and data analysis. So again, we're going to talk about ethics and rigor. Of course, there will be informed consent, confidentiality. We're going to be culturally competent and trauma informed around our interview practices and the questions that we ask. And most importantly is everything that we code in our codebook is going to be validated by all participants. We really are wanting them to be part of the process from beginning to end as much as possible. So we're going to have a lot of community impacts, most of them good, really. It's going to improve understanding for researchers and the community of understanding the treatment experience. It's going to support more patient-centered obesity care, and it will help uplift these underrepresented voices in the research. And there will also be implications for policy and practice. This will help improve insurance coverage. It will help reduce stigma and will actually help inform, medical provider practice and improve communication and support for patients. Public health messaging, we could really fine tune more to be more inclusive of this population and much less shame-based. So next steps going forward. This research will be disseminated to public health partners, run the gamut of different kind of stakeholders with that. In the future, we'd like to explore more longitudinal and visual storytelling methods after we do some initial research. And this will actually help inform more future research and advocacy efforts. Before I conclude, I did want to give a slight reflexivity statement around this research and acknowledge my own biases. And I myself identify as a fat person. And I am also on one of these medications. So I do acknowledge that the lens through which I'm looking might be a little bit skewed when it comes to this research, even though I will try to minimize that bias as much as possible. But I think that is important for you to know. With that, that concludes my presentation. And if you have any questions, please do reach out. I look forward to them. And thank you for coming to this presentation. I appreciate it and have a nice day.